Inpatient Services. Right off the bat, I wanted to get started with acknowledgements. This study was very much a team effort. We had contributions from a broad range of patient and caregiver stakeholders, provider administrative stakeholders, hospital staff, both at Mission Bay and San Francisco General Hospital, and a team of close to 50 people who were involved in the study. And so really, I am one representative of a large team that made this work possible. And in addition to people acknowledgements, I also wanted to take a moment to have healing practices acknowledgements. I'll be discussing a study that looks at both acupuncture and pain counseling. And it's important to acknowledge that acupuncture is just one part of a whole system of medicine that dates back to 3 BC or so, well over 2,000-year history of this medicine. And for the purposes of the study, we're looking at one component of a very complex system of medicine. And then we'll also be talking about pain counseling, which is adapted from cognitive behavioral therapy, so not straight ahead cognitive behavioral therapy. And in terms of my own positionality looking at this research, I wanted to share that I'm a first-generation Chinese American. Professionally, my background is in public health with a focus on socio-medical sciences. And so my lens is through sociostructural factors, looking at public health equity issues. And importantly, I am a non-clinician. And so that slide before, that whole team, it was really created and assembled intentionally to fill gaps in knowledge. So expertise in Chinese medicine, as well as clinical psychologists and hospitalists, a very large team that sort of filled the gaps in knowledge to be able to create this study. And then the last point that I'll make about my positionality is that I've now been at UCSF for well over a decade. And so the lens through which I'm looking at integrative medicine is really institutionally based within this academic setting. Okay, so a little bit more background on the study. We focused on inpatients with cancer. Cancer is the second leading cause of death in the United States, and we focused on inpatients with cancer specifically because there are close to 3 million hospitalizations each year. Of those inpatients, more than 50% experience pain, and 1/3 report that they're not receiving adequate pain relief. And importantly, racial and ethnic minorities are much more likely to experience undertreatment of pain. So in addition to the immediate burden of physical discomfort and suffering, unrelieved pain results in a range of worse outcomes that include things like longer hospital stays, decreased functioning, and a higher risk for long-term chronic pain. The mainstay of pain management, both inpatient and outpatient, continues to be analgesics, opioid medications, and effective as they might be, they have a very serious downside. And so for this study, we were really focused on this patient. Let's see my slides. Okay, there we go. Our study focuses on this patient-centered question of how can I get the most pain relief with the fewest side effects? And our approach to addressing this question was to test combining pharmacologic and non-pharmacologic treatments to see how we could maximize the effectiveness of pain management, looking specifically at pain intensity and quality of life, and then minimizing harm from pain medications, so opioids as well as their side effects. And then a third, looking at how the combination of pharmacologic and non-pharmacologic treatments could align with patient preferences. And so non-pharmacologic treatments, it's this very large bucket. For the study, we did focus specifically on acupuncture and pain counseling, primarily because of the existing evidence base. And so for inpatient acupuncture, there is, sorry, my slides are acting a little funny. Okay, so in terms of inpatient acupuncture, there is a robust evidence base that acupuncture based on RCTs and meta-analysis that cancer patients who receive acupuncture, that it can reduce chemo-related nausea, as well as vomiting compared with sham acupuncture. And then also evidence that suggests that when acupuncture is used as an adjunct to pain meds, that it can reduce pain intensity by about 36% compared with medications alone. And then in some of our prior work at the Osher Center, we also noted that there's considerably high demand for acupuncture. About 75 to 80% of patients, when they're offered acupuncture, say, yes, absolutely, I'd love to try that. And despite some of the existing evidence base, there are some knowledge gaps and clinical practice gaps in terms of thinking about how we would implement acupuncture on an ongoing basis. Unlike medications, acupuncture is never going to be available 24/7. So there are important questions around which patients would benefit most, and then also questions around how it might compare with other non-pharmacologic approaches that it might be more easily accessible. The other non-pharmacologic approach that we wanted to test was pain counseling. We chose this approach because of evidence-based guidelines that endorse psychosocial and educational interventions that can address patient barriers to pain management. And to unpack what pain counseling is a little bit, it includes addressing patients' attitudes about pain, increasing their knowledge about pain treatments and side effects, communication with providers, as well as promoting coping skills. So things like changing maladaptive beliefs, managing stress, and self-monitoring. So as I mentioned, pain counseling is included in evidence-based guidelines, but the majority of the prior research that's been conducted has been focused primarily in outpatient settings and primarily in populations that have been predominantly women and non-Latino whites. So this gap in terms of inpatient data from clinical settings that are serving diverse populations is needed in order to confirm some of the literature and research on outpatient pain counseling. So as a little bit of background, this is from the National Center for Complementary and Integrative Health. This is a spectrum of research that goes from basic science, answering questions like how does it work, all the way to dissemination and implementation science that is looking at given a solid evidence base, how can we actually uptake in various clinical and community settings? And so given the existing evidence base, this research that we developed essentially said, okay, the efficacy data in this red circle is pretty solid. What we're really looking at doing is translating efficacy into effectiveness and hopefully towards implementation. So the question that we were interested in answering was around, is it effective when implemented in real world conditions? Just a little bit more about pragmatic research. Classical RCTs represented in this upper left-hand corner are really the gold standard of research and designed to eliminate as much noise as possible. So really trying to maximize internal validity. And so there tend to be very strict eligibility requirements to get into the study, as well as prescribed study interventions, again, just eliminating as much noise as possible. For pragmatic trials, the idea with pragmatic trials is that they're trying to balance classical RCTs with what could happen in community clinical practice. And so this seesaw idea where pragmatic trials are intended to be much more representative of patients that would be in clinical practice while still meeting as much of the rigor that you would expect in classic RCTs. Okay, so when we were designing PRACXIS, some of the design considerations we were thinking about, first and foremost, we were thinking about equity and really wanting to ensure that the study that we designed included broad heterogeneous patient populations and defining heterogeneity in terms of income, race, ethnicity, language, and also clinical diagnosis, and trying to fill some of the gaps in terms of integrative oncology, non-pharmacologic symptom management, and prior studies that have focused primarily on cancer survivors or exclusively on breast cancer. Our study was interested in patients that were undergoing active treatment during current hospitalization. And then the final point about equity was really just trying to have a patient-centeredness in every stage of the work that we were doing. And then again, going back to that idea of pragmatic trials and wanting to balance and maintain as much of the rigor that you would get in a classical RCT while still moving towards the messiness of real world settings. So our study was focused on effectiveness, and we made design choices to be as unbiased as possible to maintain internal validity while also looking at external validity, which is just the generalizability of our study findings. And then importantly, looking at ecological validity also. This isn't talked about quite as much as internal and external validity, but it's essentially the idea that the interventions and the things that are included in the study actually reflect clinical practice. And so for acupuncture research in particular, there's been a lot of critique within the acupuncture community among the acupuncturists who are actually doing the clinical practice that many of the RCTs don't reflect what they do. And the idea of sham acupuncture doesn't make sense. And so we teamed up with the amazing acupuncturists at the Osher Center, and Jen Ashby in particular really spearheaded the development of treatment manual that could be standardized and reproducible within a clinical trial, while also staying true to the medicine and principles of East Asian medicine. Okay, so those are some of our design considerations. And what we ended up with was a study that happened at 2 sites in 3 languages and 4 arms. We chose to do a 2x2 factorial trial that looked at acupuncture, yes, no, pain counseling, yes, no. So those are the 4 arms. We did the study at Mission Bay Hospital and San Francisco General, and then the 3 languages that were included were Cantonese, English, and Spanish. And the other piece referencing back to the NCCIH framework, we designed this as a hybrid study looking at both effectiveness and implementation. And so the effectiveness component of it is the 2x2 factorial, where interventions were offered daily up to 4 days, and patients were first recruited into the study to they were recruited into the study under the auspices of helping with a trial around pain management, a study around pain management. And then we chose to have a separate 2-tiered consent process, because in some of our prior work, we found, if you tell somebody that they could enroll in an acupuncture study and they enroll because they're excited about getting acupuncture, and then they're randomized and get randomized to an arm that doesn't get acupuncture, they get incredibly disappointed. And so we opted for something called a Zelen design, where the randomization process happened outside of the consent process. So folks were invited to participate in pain management study. After they consented to that, we randomized them to one of 4 arms. And then if they were randomized to a study intervention, then we would consent them to the study interventions. Okay, so that's the effectiveness part. And then in terms of implementation, we had a very robust qualitative data collection, which I'll get into more detail in a bit. For the factorial study, staying true to our pragmatic approach, we had a pretty broad eligibility criteria. So anyone with a malignant solid tumor with length of stay of over 2 days, a pain intensity of 4 out of 10, adults who spoke one of the 3 study languages. And then the exclusion criteria were essentially inability to consent, unstable medical condition, and then certain thresholds for platelets and neutrophil count. Our amazing team of research coordinators ended up screening 2,900 patients, and we ultimately excluded 2,400. Most folks who were excluded were due to length of stay. A lot of the folks at Mission Bay Hospital in particular, are their anticipated length of stay is for less than 2 days, and so they were disqualified for that primarily. We ultimately consented 451 inpatients that met our eligibility criteria, and then 4 of those folks ended up being removed. We discovered they were ineligible after they had already consented. So just in terms of a little more detail for our enrollment, we had originally hoped to recruit 480 patients. Our study got paused in March 2020 due to shelter-in-place mandates. We were fortunate that we had just hit the 50% mark of our recruitment. Ultimately, we recruited 451, and a quarter of those patients were from San Francisco General, and then the rest were from Mission Bay. So who ended up in our study? We, in terms of race and ethnicity, this is broken down by our 2 sites. You can see that San Francisco General has a much more diverse patient population than Mission Bay. It was really critical in terms of our study sites and being able to meet some of our equity considerations that were really at the central to the study. In terms of other demographic characteristics, average age of our participants was 59, pretty even split by gender identity, and then education fairly representative of the San Francisco Bay Area, with folks with college education or more being over 40%. And then in terms of language, we had 86% English speakers, 11% Spanish, and 3% Cantonese. So clinical characteristics, we achieved our goal in terms of clinical heterogeneity. We had cancers of all different types. 78% of the patients had non-metastatic cancer, and baseline pain was 7.6. Okay, so I'm starting to move into sharing study findings, but before I do that, I just wanted to take a step back and talk about the statistical analysis of a factorial trial. Because patients are randomized in this 2-by-2 fashion, the main effects of the study and the primary analysis of a factorial trial looks at what's called the estimates of the margin. So being able to look at pain counseling versus pain counseling versus no pain counseling, and then acupuncture versus no acupuncture as the two main effects. And so not necessarily looking at inside the box, but these margins on the outside. And then one other note is that we conducted both intent to treat analysis as well as per protocol analysis. And the big difference between those two, intent to treat, is essentially we're including everybody who got randomized, regardless of whether or not they actually received the intervention. Whereas for per protocol, we're looking at people who actually received at least one of the interventions that they were assigned to. So just noting that for our intent to treat analysis, we included 447 patients for most of our analysis. And then for the per protocol, you can see quite a steep drop off to 309 patients, because lots of the folks who got randomized to either acupuncture or pain counseling, they either ended up not consenting or they consented, but due to a range of factors, ended up not actually getting the intervention. All right, so on to study findings. So change in worst pain intensity, this was our primary outcome, and looking at the margins, big disappointment when we were looking at this. You can see that for pain counseling, it's essentially regardless of whether you got pain counseling or not, you had a daily decrease of about 0.6. And then for acupuncture, those who received acupuncture had a decrease of about 0.6 each day compared to 0.5. So these are not statistically significant and a barely noticeable difference. Then we decided, okay, it's a factorial trial. We do want to actually look at what is going on inside the box. So looking at the 4 different arms, and here we see that the largest decreases were actually for folks who received acupuncture but no pain counseling. And for them, there was a daily decrease of 0.7 compared to usual care people who had a decrease of 0.4. Notably, this still was not statistically significant and arguably probably not clinically relevant either. But again, noting that this is the intent to treat analysis. So it includes all the folks who were randomized, even if they didn't actually get the intervention. Okay, so then looking at our per protocol analysis, you can see that as you would expect, folks who actually got acupuncture did have a greater decrease. So here, the estimates for the people in usual care stays about the same, 0.4, which is what you would expect, because that sample isn't really changing from the intent to treat analysis compared to the per protocol. But for the folks who received acupuncture, here they're decreasing 0.8 per day. And even that may not be clinically relevant on a day-to-day basis, but over the course of a couple of days, this actually translates to 3.3 decrease for acupuncture compared to a 1.7 decrease for usual care. And the interaction for this actually was statistically significant. The other thing that I'll point out here is that for the folks who received both acupuncture and pain counseling, we were surprised that it almost seemed like they counteracted each other. So what's referred to as an antagonistic interaction, where the 2 study interventions did not have additive value, but actually counteracted each other. So that was one of our surprising findings. So I'm not going to share findings from all of the outcomes that we looked at, but this one is for pain medications. And again, you can see that when we're looking at the margin main effects analysis, it ends up masking some of what is happening within the box. And so this is the intent to treat analysis of pain medications per day, looking specifically at oral morphine equivalent. So based on the intent to treat analysis, we're seeing for the folks who got pain counseling and acupuncture, it looks like they have the biggest decrease compared to usual care, which is a 0.2 decrease. And then looking at the per protocol analysis, this is amplified even more, that pain counseling and acupuncture, in contrast to the pain intensity finding where there's an antagonistic relationship, here we're finding acupuncture with pain counseling has a synergistic relationship where the decrease is close to 3 OME per day. This is just a graphic representation where you can see the pain counseling acupuncture arm has the steepest decrease. Okay, I want to make sure that we have time for Q&A, so I'm going to go through some of this pretty quickly. We are still unpacking subgroup analysis, diving into whether or not there's heterogeneity of treatment effects. It looks like there is potentially some difference in terms of where folks started in terms of their symptoms at baseline. Age and income may also predict some of the effectiveness of both acupuncture and pain counseling. And then notably, we also looked at differences by site. And what you're seeing here is the dotted lines so dotted blue line is Mission Bay no acupuncture, dotted red line is SFGH no acupuncture. And when you compare just the two dotted lines, you can see that there's quite a bit of a difference, and actually a statistically significant difference. The outcome on this slide is pain relief, so higher is better. And essentially what it's saying is that pain relief with usual care at San Francisco General, those patients are faring much worse than Mission Bay patients. And then when you compare the two solid lines, UCSF and SFGH for the folks who received acupuncture, what we're seeing there is that there's still a difference, but it's actually minimized to a certain degree. And we see that same pattern with pain counseling, where there's a big difference in patients at the two sites who did not receive pain counseling compared to folks who did receive pain counseling, where it seems like non-pharmacologic interventions might help to minimize some of the disparities in pain management at the two hospitals. Okay. I'll share briefly that our qualitative component of the study drew very heavily from implementation science frameworks and guidelines for process evaluations of complex interventions. We conducted interviews in 3 different phases. Phase 1 was focused on our local context, the 2 hospital sites, and looking specifically at questions around intervention fidelity and whether or not adaptations were handled in a way that could still stay true to the manuals that we had created for the study interventions. So that included 11 interviews with all of the study interventionists that participated in the study. Phase 2 was more of a national landscape of integrative medicine, looking at 14 different hospitals and interviews with 35 different practitioners. And then phase 3 looks specifically at patients and caregivers with diverse racial and ethnic identities, and those interviews were conducted in English and Spanish. So I'll say that the qualitative interviews in many ways were much more straightforward. There's a lot of stakeholder support. This is one provider perspective who says every patient in the Bay Area is interested in integrative oncology. If they weren't before, once they have a cancer diagnosis, they're interested. And UCSF really needs to provide our patients with access to these services as part of comprehensive care. Here's a quote from one of the patients who said, "I could barely speak because my pain was so strong." It was a 10. They gave me fentanyl patches from 25 that kept increasing to 125. Then they gave me methadone. The acupuncture took away my pain and helped me relax. Before acupuncture, sometimes I couldn't sleep all night, but the acupuncture put me to sleep for 3 hours. It could bring my pain down to a 4. And then for another patient who had received pain counseling, who said, "I was in so much pain when the pain counselor arrived that day. I was almost at a 10, and I told her I could barely speak, but I was going to try. The session put me right to sleep, and she told me I could stay there and relax, and I slept for an hour or 2. So these stakeholder perspectives, we are in the process of developing a manuscript that looks at some of these push-pull factors, that looks at some of the mandates or recommendations from the Joint Commission around including non-pharmacologic approaches and what the limiting factors are. And for the sake of time, I am going to transition pretty quickly to some of our lessons learned and then loop back to some of those design considerations. So lessons learned, we did this at 2 sites. At the academic medical center, the intervention staff had much more established relationships with the hospital staff, and the oncology patients were located in fewer wards. So these factors really facilitated our study recruitment, and basically every aspect of setting up the study at the safety net hospital took so much longer. And that was essentially because there was no precedent for so much of what we were doing. Just the process of getting licensed acupuncturist privilege, the approval process to recruit patients, all of that. There was complexity within the hospital system that was in place, and then also just really acknowledging the complexity of the patients that were getting treated at each of the 2 sites. At San Francisco General, patients were diagnosed at a much later stage and managing sociostructural inequities. In terms of the practitioner level, interpersonal relationships between the interventionists, our study staff, and the hospital staff were a key to successful implementation. And that was true for sure at both sites. And one of the things that we did well, actually, because we were having acupuncturists at the hospital for the study, it also allowed us to expand access to acupuncture to the hospital staff, as well as to patients who were not eligible for the study. So we referred to these as off-study treatments, and it greatly increased the staff buy-in, and it also helped to provide patient care without burdening staff. In terms of the patient level, it's notable for us that the interventionists had to be making real-time patient-centered adaptations throughout. And so this included working in culturally nuanced ways with non-English speaking patients, adjusting treatment based on patient symptoms. Sometimes caregivers ended up being part of pain counseling sessions, and then just modifications in language to ensure that the intervention was acceptable. And I'm happy to share more details about that in the Q&A if it's helpful. So looping back to some of these design considerations that I brought up in the beginning, in terms of equity, I would say some of what we did successfully, we recruited diverse heterogeneous patients. The study had a patient stakeholder team and also maintained a patient-centeredness just from the get-go in terms of the research question and ongoing throughout. And then one of our greatest sources of pride is that we actually got inpatient acupuncture credentialed at SFGH for the first time in its 100+ year history. Some of the challenges in terms of equity were that we recruited much fewer Cantonese-speaking patients than we had anticipated. And then while the study is fairly diverse, it was not fully representative of San Francisco racial ethnic diversity. And then in terms of rigor and reproducibility, this is not so much strengths and challenges, but lots of trade-offs every step of the way. So the heterogeneity of patients is such a great strength in terms of generalizability and external validity. And it makes some of our subgroup analysis very difficult, and also can add a lot of nuance in terms of how we're interpreting the data. And then again, looping back to the interventions and how they were flexible but manualized, I'd say that we were successful in terms of the ecological validity and mixed, because some people would receive one treatment, some people would receive 3. And so that part of it wasn't standardized and also reflective of what happens in real clinical settings. The Zelen design, that idea of having a 2-tiered approach, we had pulled that off successfully in a prior study, thought it would be fine in this one as well, but it didn't work as well. And so that difference between intention to treat analysis and per protocol analysis continues to be painful for me. We lost so many people in those analysis because lots of patients who were randomized to acupuncture and pain counseling didn't get it. And so the intention to treat for the study intervention arms includes a lot of usual care patients, which arguably probably makes the difference compared to usual care. It minimizes the potential for seeing those differences. And then the interaction between pain counseling and acupuncture, we thought about it beforehand. We thought about it as an exploratory analysis. Never would I have guessed that we'd have a synergistic interaction for one outcome and an antagonistic interaction for another outcome. And so I think it's interesting. I think that it actually, we're still mulling over the implications and what that could mean for clinical practice. But in terms of the analysis, we were underpowered for the analysis that looks at those interactions. Okay, I really do want to switch to Q&A, and I do want to end looking again at our study overall, specifically through this equity lens, and 3 points in particular in terms of some of our lessons learned. And the first is just how critically important it is to plan for complexity. The staff that were working on the study, they needed to be supported in being flexible in terms of handling disparities in real time and on multiple levels. What this meant was that our research coordinators were doing way more than consenting participants in recruiting and data collection. They were taking on responsibilities like patient advocacy, language translation, reaching out to social workers, a range of different activities that aren't formally part of the study. The second point is that ensuring equity requires considerable resource commitment. So having diverse patients in research and clinical programs, it takes more time, it takes more work, it takes more resources. So we were devoting about the same level of staffing at the 2 hospitals, and the recruitment yield at the academic hospital was 3 times higher. And so for us, with equity as a central focus, going into the study, planning for that is so critical, to be clear about our priorities and what it actually takes to meet those equity goals. And then the third point is just this idea of centering at the margins and how critical that is to reduce barriers to participation for diverse populations. We saw this predominantly in terms of how interventions would need to be tailored to be effective for a range of patients, and also found that these types of adaptations yielded benefits not just for the minoritized patients, but also for the majority. Okay, so I will close with just another shout out to the amazing team that worked on the study, and I am happy to take all questions, comments, critiques, etc.
Thank you so much, Maria. Folks are welcome to turn on your cameras if you want to, and we have lots of questions for you. You're welcome to keep sending me questions in the chat, everyone. Let's see. I think we're going to start with a couple of more practical questions about the interventions. So one, you touched on this a little bit, but maybe you can say a little bit more about what the pain counseling entailed and how it differs from usual care that people are getting in the hospital.
Okay, so the usual care, patients would potentially have nurses that would check in with them, do daily questions around pain levels, etc., but not necessarily any coping skills. And so the pain counseling was developed by a clinical psychologist who focuses on cognitive behavioral therapy. It draws from that as a basis, although it's not strictly CBT. It included things around pain education, our beliefs around pain and pain treatments, and then also providing coping skills like guided imagery and deep breathing.
Thank you. Jennifer, do you want to ask your question?
Thank you for that awesome presentation. Question, can you speak on your thoughts about, I know that you were measuring a certain period of time, 1 to 4 treatments. Can you speak on what the trend looked like for acupuncture if those patients might have been able to receive more acupuncture like they might in the real world setting in a longer inpatient scenario?
So this is a tricky question to answer because patients in the hospital, first of all, I'm laughing that I'm saying this out loud to you, Jennifer, because you could certainly answer this question much better than I could as a licensed acupuncturist who worked on the study. But one thing that I'll say is length of stay is all over the place, right? And so there are patients who are in the hospital for 2 days or 3 days. And for those patients, getting just one treatment actually can have an impact. And those patients are potentially the patients that may not have as many symptoms or may be recovering much more quickly. So on the one hand, I feel like, even just one session of acupuncture can potentially make a difference for some patients. And then that idea of a longer term trajectory, or the idea of better continuity and coordination between inpatient and outpatient, is something that I'm hesitant to speak to, but would be really excited to research in the future. Do you want to pipe in with your thoughts about that?
More in this case would always be better, especially with a trajectory that's showing any positive outcome with 1 to 4 treatments, which is what we might have to do in a short hospital stay, but not really the way we would do it without those restrictions. We would see them more. And so I think that it was actually a really good study for acupuncture, that if we'd had more or longer, we would have seen that trajectory. Although I am biased, that trajectory numbers would have gone up.
Okay, there are a couple other questions. One is whether you can share your article citations, which I can probably do in the chat. A couple of questions about pain and measuring pain that somewhat relate to what Jennifer just brought up. So one is, was there a cumulative reduction in pain intensity over time within the per protocol analysis? So with the idea that from the patient perspective and the clinician perspective, a change in pain over a week or a month might be more relevant than pain reduction per day.
Right. So the pain reduction per day is the same as looking at the slope of the line. And so the cumulative reduction, we do anticipate that that is more. And part of the reason why we looked at it that way is we were using a linear mixed models approach where we could retain all of the participants in the study, regardless of whether they only completed 1 follow-up versus 4 follow-up. And so we ended up reporting it that way in terms of change per day, but it is exactly the same thing as just like how steep the line is, the slope of the decrease.
All right, somewhat related question. Do you have thoughts about whether pain intensity or pain medication use may be a more accurate reflection of the pain experience of the patient? And wondering about if the effects in medication might be related to clinicians judging the necessity of pain meds, or if that's not a big issue.
Okay, so in terms of the pain experience, I think it's so critical that we have a range of measures. I don't think that there's a single quantitative measure that could actually capture the pain experience. When we're doing outpatient chronic pain, we're actually much more focused on pain interference and quality of life and those types of measures that can be a little bit more comprehensive. So that was the first part. And then the second part, I'm not sure that I fully followed. It was about providers.
Yeah, like the decisions about pain medicines maybe are that the clinicians are judging whether or not patients need more or fewer pain medicines, and how those decisions about dosing might relate to the findings, I guess.
Yeah, no, I think that that's absolutely true. Type of cancer, type of treatment, what hospital, a range of really important contextual factors that had nothing to do with the study.
Okay, we have a few more minutes, so if people have more questions, feel free to send, but there are 2 questions about the Zelen design and randomization decisions. So Jen says, Zelen design is such an interesting idea. Why do you think it wasn't as successful here as in your previous work? And what sort of feedback did you get from participants about this design? And then maybe I'll just ask the other Zelen question at the same time, which is, if you were going to design the study again, can you imagine an approach that would enable you to randomize and consent at the same time to minimize such a big difference between the intent to treat and per protocol sample sizes?
All super great questions that I've continued to think about a lot. So in our pilot study, we added an additional question or an additional series of questions. So we invited people to be part of a study of inpatient pain management. And then as part of their baseline survey, we said, hey, if these types of approaches were offered in the inpatient setting, would you be interested? And so we asked about mindfulness, nutrition, acupuncture, a whole bunch. And we only randomized patients who said that they had at least a moderate level of interest in acupuncture. And so we were able to sort of weed out people based on interest prior to randomization. So we did not do that in this one, thinking that it wouldn't necessarily make as much of a difference as it did. I think that the uptake of acupuncture actually was still quite high, but one of the differences was around pain counseling. And so the uptake for pain counseling was much lower than we had anticipated. And then in terms of the other question, in terms of randomization and consent at the same time, I think for me now, the trade-offs of using the Zelen design, the cost is too great. So after our first experience with the Zelen design, I was sold on it. I thought it was a really great approach because the benefits of it are essentially like you're reducing disappointment bias, and you're able to maintain blinding all the patients who are randomized to usual care. They don't know that there's study interventions that are happening. And so that idea of being able to have blinding, less selection bias, you're not just recruiting patients who are already enthusiastic about integrative care. But now after PRACXIS, this version of PRACXIS, that the big difference, I think that the trade-offs they feel too great to me. So I probably would go ahead with a straight ahead randomization and consent. But I think I'd have to think about it a little bit more depending on what the study is.
All right, if there's anyone who wants to speak up, one final question, if it's pretty short, you're welcome to do that. And I just want to announce our next research seminar, which is going to be on Tuesday, January 24th, with a guest speaker, Rico Chenyek, speaking about a politicized healing. Here it is, right before you. I'm going to put the registration link in the chat. Okay, Maria, I think we'll let people give you the rest of their questions at another time. Thank you so much for that wonderful talk. Thank you everyone for being here. Have a great rest of your day.
Thanks so much for coming, everyone. Scanning.
Oh, let me turn off the recording.